Good evening, everyone, and welcome to the Illinois Pain Institute webinar. We are so excited you've joined us tonight. We are going to wait just 2 minutes to allow a few more attendees time to log on. We will start the webinar promptly at 7:02. Thank you so much for joining us. We will start promptly in 2 minutes. Good evening, everyone, and welcome to the webinar produced by the Illinois Pain Institute. We are so excited that you've joined us this evening. We will begin the webinar promptly at 7:02 to allow a few more callers time to join us. Again, thank you so much for joining the webinar. The webinar will begin shortly. Good evening, everyone, and thank you for joining us on the webinar produced by the Illinois Pain Institute. We are so glad you've joined the webinar. We will start promptly at 7:02 to allow a few more callers time to join us. Again, welcome to the webinar. We will begin the program shortly. Good evening, everyone. Welcome to the webinar produced by the Illinois Pain Institute. This webinar is going to focus on the latest proven diagnosis and treatments of pain and spine conditions in the COVID-19 era. I would like to introduce our moderator, Dr. John Prunskis. Dr. Prunskis, take it away.
Great, thanks very much, and thanks everybody for joining what is our first in what we intend to be a series of webinars that we will hold periodically on updates in diagnosing and treating painful conditions regarding the spine and other parts of the body. The panelists that we have tonight are all physicians on staff at the Illinois Pain Institute, and I will spend just a moment introducing all of them. Some of them you know, some of them are your doctors. And first, Dr. Chadi Yacob. He is board certified, also has received the highest international designation of Fellow of Interventional Pain Practice, and he completed his residency and fellowship at Wayne State University. He has authored and co-authored numerous scientific articles, and is a member of our both pain societies and our local medical societies. Dr. Bradley Silva is not only a physician, but before he saw the light, he was an attorney, and he is board certified in anesthesiology and pain medicine. He has a broad experience, as do all the doctors at Illinois Pain Institute, on the diagnosis and treatment of painful condition and the latest proven, and I want to stress proven, interventional techniques, not just those that are available. And he attended Tulane University for his undergraduate studies, graduated with honors from George Washington University Law School, and graduated at the top of his class at Chicago Medical School, the Rosalind Franklin School of Medicine. And he completed his residency and fellowship, where I did, at the University of Chicago. And as with all the doctors, he focuses on a compassionate care and again, the diagnosis and treatment of painful conditions. Dr. Anka Bellinger is also fellowship trained, as all of us. She has a passion for the accurate diagnosis and treatment of painful conditions, and to restore the highest level of function and quality of life possible. She focuses on a highly personalized, problem-focused approach to patients, and of particular interest to her are back and neck pain, disc issues, sciatica, musculoskeletal pain, and other nerve-related conditions. She completed her medical studies in Germany, then went on to complete her residency and fellowship at the University of Iowa, where she was assistant professor and director of the VA Pain Clinic. And she also is board certified and a member of our major pain societies. And we're delighted to have her on the panel tonight and part of our Illinois Pain Institute team. And I'm Dr. John Prunskis. I'm the medical director of the Illinois Pain Institute, and I'm also a presidential appointee to the Health and Human Services Best Practices Pain Task Force, where last year I co-authored what is now the standard for diagnosis and treatment of painful conditions in the United States, and has been endorsed by every single medical specialty as the way pain should be diagnosed and treated. I completed my medical studies at Rush and did my residency and fellowship, as I mentioned before, at the University of Chicago. And I share with our whole Illinois Pain Institute team that just this last week, for the 11th time, they named us, our peers, I should say, our physician peers, selected us to be as the top pain doctors in Chicago. And that's an unprecedented count. No other practice has received it that many times, and we're humbled and honored that our colleagues feel that way about us. I would like to also touch base before we go into various clinical scenarios that we're going to talk about the COVID-19 and how it relates to your care. First of all, we are not in a hospital. We are freestanding, accredited. We have an accredited freestanding ambulatory surgery center. We have freestanding procedure facilities. And quite frankly, I have not stepped foot into a hospital since January. And at this point, I don't intend to, unless I, for some reason, have to. We do not treat patients who have COVID infections at any of our centers. We practice all CDC guidelines to protect our staff and our patients. And we pre-screen with phone calls patients who are scheduled to come in to make sure they don't have any fever or symptoms that are consistent with the COVID virus. We also have signage outside of each of our centers to, if people have any of these symptoms, to not even come in. Visitors are not allowed to accompany patients. They have to wait in the car. And then when patients come in, we check their temperature and take a history to make sure they have no COVID-19 symptoms. So we are keeping COVID-19 out as best we can, again, we are not treating any COVID-19 patients at our facilities. And before we get into the diagnoses, something that is now new is what's called telemedicine. And some of you may have taken advantage of this. And that's now where you can call us. We can have a audiovisual meeting, just as we are tonight, where we can see each other. Or if you just want to do it on the telephone, we can do it through Skype, Facebook, Zoom. There's other ways that we can do it. And we can help not entirely duplicate a face-to-face exam, but in some cases it's almost as good. And one thing that you can do to prepare for these telemedicine consults, whether it's with us or any of the other doctors, is check your temperature so you can tell us that you don't have a fever. If you have the ability to check your blood pressure, your pulse, your respirations, if you know how to do that or have the ability to do that, that'll give us just an idea of your overall health. And then if we have a camera interaction, such as tonight, we might ask you to do certain maneuvers just to see what elicits pain, etc. So now, with that introduction, what I want to first do is, again, this is the first of several webinars, and we'll start this webinar with Dr. Silva. And Dr. Silva, back pain is one of the most prevalent medical complaints in the United States. It has a huge impact. And how do you approach your care to a patient who has back pain?
Well, I think for me, the first step is listening to what the patient has to say about their pain. You're correct, back pain is probably the most common presenting pain condition that patients go to their doctor for, but it can be incredibly complicated. And what I first try to do is figure out, is this purely back pain, or is there any component of leg pain? Because that can pretty quickly help differentiate what might be the underlying etiology. I also will talk to the patient to get a sense of the quality of the pain, meaning is it sharp and stabbing, is it aching, Is there any numbness or weakness in the leg? After that, I'll conduct a physical exam, which will help to kind of refine what I think the possibilities are. I'll check for strength in the lower extremities, the legs. I'll check for any changes in sensation, check for any areas that are particularly tender or painful. And then finally, with those pieces of information in mind, it helps guide what appropriate imaging would be necessary. We usually, especially for most of our patients who are, we've been seeing for a while, are familiar with MRIs. And the thing that an MRI does that an X-ray cannot is an MRI can let us see the tissue, the discs, the nerves, and it can give us a lot of very important information as to what the underlying cause may be, and even more importantly, where the problem is, because the back is, a complicated structure of the body, and it can be very useful and important to know not only whether it's a nerve, but what nerves are actually involved.
Great, very good. Thank you. And Dr. Jakub, what else do you do, or any other thoughts on the diagnoses? And maybe you want to touch base on some of the treatments that you consider in back pain. And also, I'll include sciatica with that too, because as we know, sometimes people can have sciatica and leg pain. The problem comes from the back, but they don't actually have pain in the back.
Sure. As Dr. Silva mentioned, the first thing to do is find what's the cause of this or diagnosis. Other form of test that might be done is also the EMG or nerve test, which will help us with the sciatica pain. After finding what's the cause, sometimes it's more than one. The first thing to start with is prevention, like avoiding heavy lifting, excessive bending, twisting, adding some medication. Some over-the-counter medication might be effective, like Advil or Aleve. If that's not the case, some different medication can be added, like stronger non-steroidal anti-inflammatory medications, or some nerve medications like gabapentin, Lyrica, or Cymbalta. Another thing that might help is also physical therapy. It might take sometimes up to 8 sessions to feel relief from physical therapy. If this is not enough or not giving the patient enough relief, other things that we can do is let's say less invasive injections. This is a technique to give the patient some relief without going for surgery. This includes epidural injections and some joint injections, like facet joint injections or sacroiliac joint injections. A facet injection is typically for a patient who has pain when flexing backward. This pain is typically not shooting down to the legs in most cases. It might take 1 or 2 sets of injections. If the relief is good but not lasting enough, another technique might be used, which is radiofrequency lesioning, where we can heat some nerves or cauterize the nerves, which can give them relief for that might last between 4 to 12 months. Epidural injections is basically for pain that might be shooting down to the legs, or sciatica pain, which might be only in the legs also. This might take 1, 2, or 3 sets of epidural injections, and it depends on the response. It can be repeated if needed, if they have good response. Another thing also is there is different form of joint injections, like sacroiliac joint injections, but this depends on the case, on the clinical findings.
Great. Anything else? Anything else come to mind?
There is also some nerve blocks. So there is different technique to avoid going for certain bigger surgeries, let's say.
Sure. And I know at the Illinois Pain Institute, we have a very low referral rate to surgery because we're able to successfully, with the minimally invasive techniques that Dr. Silva mentioned and diagnosing them, and Dr. Jakub touched on some of the techniques to help fix the problem. One thing, Dr. Jakub mentioned epidural injections. And sometimes patients will come to us and say, well, I've already had the epidural injection and it didn't help me. The thing that you have to remember is there are different types of needles. Some can allow us to get closer to the areas that are problematic than others. And these needles are actually more expensive. We use them, and some facilities might choose not to use them. There's also different medications that can be used that have different benefit ratios that might have been not used in prior injections, and then also the techniques that the physician may have used may have been different than ours. And when Dr. Yacob was mentioning these injections, most of our patients get sedation for these injections, so that's a comfortable procedure. It's not a general anesthetic. You're kind of in a twilight, and if you would like more sedation, you ask for it, you get it immediately. So the procedure itself is relatively pleasant, and so our patients don't have to be fearful that any of these procedures might be painful. Dr. Bellinger, what else might you want to add to the either diagnosis or treatment of various types of back or sciatica type conditions?
Yeah, so there are some more advanced therapies apart from these injections. One is, for example, if the sacroiliac joint injections have helped, but they don't last very long, that we insert small bone pieces into the sacroiliac joint to stabilize the joint. So that's a great procedure. Another procedure is to perform neuromodulation, so modulate the pain on spine level, and that might help with chronic low back pain, with radicular pain, which means the pain is radiating into the legs. So that are more advanced procedures that can be considered after other injections have been done before.
Sure. For those patients, again, who've had neuromodulation or spinal cord stimulation in the past, some of them want to know what are the advances that have been made in the neuromodulation or stimulation, and there have been substantial. Number one, battery life or generator life has been significantly lengthened. The size of the battery of the generator is smaller so that it doesn't have to be changed, or if it's a rechargeable battery, the charge lasts longer. Also, with some of the newer neuromodulation devices, you don't even feel that the actual stimulation device is in you. You'll feel no stimulation because the frequency is so high. So there are substantial improvements that have been made over the years. And so for those people who either have those already implanted and need perhaps generators replaced, or it's not quite covering their pain, we have options to help them. And for those patients who have not had any of those neuromodulation therapies, please remember that we first just trial the device for about 5 or 7 days. It's taped to your skin, and then you will tell us, oh, this feels good, which most patients do after our selection process, and then we can go into a more longer-term treatment regimen for them. So to summarize with the back and sciatica type pain, there are tremendous advances that have now occurred. One thing that we haven't discussed yet is called Vertiflex, and that's one where patients who have spinal stenosis, especially in elderly patients where they're using walkers or they have to lean on a shopping cart when they go to the grocery store. There's certain things we can do with just minimally invasive techniques to help open up where the pinched nerves are. Before we go on to talking about neck and head pain, is there anything that any of the doctors wanted to add about, it is a vast topic, about back or sciatica type pain that perhaps you think we might need to emphasize?
I would just emphasize that, as you alluded to, back pain is a complicated condition, and it can take time to figure out the source or sources of the pain. So when I see patients for the first time, I try to be frank and honest with them if I think that this is not clear cut, and I explain that it might take a little bit of time to figure out where this source of pain is. But if they can give me their patience, then I can provide everything I can to try to figure out where the pain is and ultimately get them as much relief as I can without having to send them to a surgeon.
Great. Yeah, I think the theme at Illinois Pain Institute that you'll hear over and over, and it's documented, and the insurance companies have verified it, that our results are outstanding without having, in the overwhelming majority of cases, to send our patients to have a surgery. Anything else, Dr. Jakob or Bellinger, that you think we might need to add, or do you think we kind of touched on the highlights?
Yeah, about regarding the a little bit more invasive procedures like the Vertiflex and the spinal cord stimulator. In contrast to the, let's say, spine fusion, which is a bigger surgery, those devices can be removed in case if needed in the future, if there is a need to perform another surgeries or different things. Those can be removed without leaving any spine damage or any nerve damage.
Right, spine surgery is forever, but these devices can be removed or changed, or as the technology gets better, replaced. Right, Dr. Jakob?
Correct.
Right. Dr. Bellinger, anything else that maybe you'd like to touch on, or do you think we?
Yeah, just that we try different modalities also. I mean, it's medication, injections, and we refer to physical therapy. So
And when you mentioned medications too, one thing, so people are always concerned about getting hooked on painkillers and pain medications. As a co-author of the Health and Human Services Best Practices Pain Task Force guidelines now, and they really, a lot of the guidelines were actually adapted from our existing policies at the Illinois Pain Institute. We're very judicious about prescribing opioid pain medications. If a patient needs painkillers, they will get them. But there are many other medications and techniques that we can use, and we do use, to keep the number of narcotics that a patient takes low while still keeping them out of pain. If we could then move on to another large topic, and they're kind of tied together in a sense, where neck pain and headache pain, neck pain sometimes causes headache pain sometimes causes neck pain, and so we have to treat those two things together. And Dr. Jakob, if you wouldn't mind kind of leading off here on when you see a patient who comes in complaining of a headache or neck pain, what kind of goes through your mind as far as, you know, differential diagnosis? What are you asking the patients? What are you looking for in physical examination?
Sure, there is many things that can cause headache or neck pain. Neck pain, headache can be due to some disc problems in the neck or some arthritis in the neck that can be causing also headache. Some nerve irritation or entrapment like occipital neuralgia can cause headache, but other forms, other things can cause headache like migraine headache or things not related to the neck area. So we need to see for how long the patient had this problem. So take again the history and physical exam. Is there any weakness, any numbness in the hands, any other symptoms? After taking the history and physical exam, we might order some tests like neck X-ray or more MRI, since as Dr. Silva mentioned, the MRI can show us in detail if there is any disc problems, nerve compression, spinal cord compression, which can cause neck pain or headache or both at the same time. Other tests might be also ordered depending on what we see. Sometimes we order a brain MRI if in the case of a headache to rule out any mass, any tumors, or any vascular problems. Most of the time it's normal. That's as far as the physical exam or diagnostic studies for this. Sometimes we order also a nerve test to see if, or nerve conduction study, to see if the neck issue is also causing some numbness, some weakness in the hands or arms, which points also to some disc problems and nerve compression in that case.
Very good. And we've talked about both back and neck pain, and we've talked about how we tend to avoid surgery. One thing where surgery is clearly indicated, whether it's in the neck or the lower back, is, for example, if you lose motor function, complete motor function of your arm or your leg, and in other words, you're dragging your leg, you can't pick things up. That's something where you need to see a surgeon right away. Dr. Bellinger, is it what else might you add for, you know, both the history or diagnosis and maybe some treatments to help fix the underlying problems so that people can return to their chosen lifestyle and again avoid any surgeries.
Well, especially, I mean, for headaches, there is not that much with surgeries, but for neck pain, I mean, we often also do occipital nerve blocks at the end, at the back of the head, or could add Botox for migraine headaches. So many headaches come from actually from the upper cervical spine, and we address that with diagnostic blocks, or also blocks that kind of address those nerves that cause the headaches. So I think that's an important topic. Yeah, that's pretty much what I think.
And you know, sometimes what we see, or what I see, and I think we all do, is when you have a problem in the neck area, it sometimes radiates to the shoulders and sometimes radiates to the head. And there's a term in medicine called cervical genic headache, where it's actually a headache generated from the spine. So our job really is to, when you come in to see one of the specialists at the Illinois Pain Institute, when you have a pain, you know, from your shoulder, neck, head, we're going to examine all those areas because they are so close anatomically, and they are related or interrelated, and pain can be referred down from the head to the shoulder and vice versa. And Dr. Bellinger used the word migraine, and most people who come in to see us and say, you know, I've got migraine headaches, they actually don't. Migraine is a very specific medical diagnosis. It has to do with the vascular and arteries in the head. But in the general public, a lot of times people use migraine to say this is a bad headache. So we're going to help determine, you know, is it really a migraine, where it's usually not, but then help determine the cause of it, share, of course, our results with the patient, and usually perform a successful treatment. Similar to the term migraine, one term that's overutilized is fibromyalgia. And we're going to continue to talk about head and neck pain a little bit, but fibromyalgia, sometimes people will come in and say, I've been diagnosed with fibromyalgia. Fibromyalgia is very overdiagnosed as well. Most of the patients who come in to see us who have been diagnosed with fibromyalgia elsewhere actually leave with a diagnosis different. Most of the pain that causes diffuse muscle spasms that some people confuse with fibromyalgia is really related to some abnormality, whether it's in the back or neck spine, but somewhere in the spine. But Dr. Silva, what might you want to add to our discussion so far regarding some treatments or other modalities that you think are important for the head and neck, and we can add shoulder pain to that as well?
Sure. Well, I think that as both Dr. Jacob and Dr. Bellinger and yourself were alluding to, is that, you know, head and neck pain can be from a variety of very different sources, unlike back pain, where even though it's complicated, you know, the area or the causes are, for the most part, joint or nerve related. You know, with head pain, you could be dealing with actual pain coming from the neck and the spine. You could be dealing with pain coming from nerves in the back of the head. You could be dealing with true headaches, which are not really amenable to actual specific nerve blocks. So it really depends on, you know, what the cause is. If you're dealing with the cervical genic headaches you talked about, which is essentially arthritic driven headaches, you know, we offer similar procedures as Dr. Jacob spoke about in the low back, which is essentially targeting the nerves to those arthritic joints, and first doing what we call diagnostic procedures, where we assess whether essentially numbing those nerves up gets rid of the headache. And then if it does, we can go back and, in addition to numbing them, we actually heat the nerves up. And there are specific nerves in the upper part of the neck that are very classic for causing really more head pain than neck pain. And likewise, there are some nerves more in the lower part of the neck that cause as much shoulder pain as neck pain. So at least part of my algorithm is figuring out not only whether there's neck pain, but is it radiating, you know, meaning is it traveling more up the head into the scalp, or is it traveling more down the shoulder? And that can give us a lot of information, not only as to what the treatment should be, but where the target, you know, what are the appropriate nerves and joints to target. And then just one other thing I'd like to just point out as a additional caveat to what you said about fibromyalgia. I often see this a lot with patients who have fibromyalgia or have migraines, or another example is rheumatoid arthritis, that it can be easy to trap yourself into thinking that all patients' pain is due to those conditions. But I have numerous patients who do truly have fibromyalgia, but they also have disc herniations. They also have osteoarthritis. Likewise, I have patients who have migraines and I treat them with Botox injections, but they also do have cervicogenic problems. So, it's important to, not lose sight of the fact that patients can have multiple conditions that are causing problems, and don't just chalk it up to fibromyalgia or migraines and that sort of thing.
Very, very true. Very true. Dr. Yakub, anything to add?
So as we can see, some patients might respond to certain specific medications, which is fine if they're doing okay with that. But as we mentioned, some injections, like for the headache part, nerve blocks, supraorbital nerve blocks, which are simple, quick nerve blocks, which might help with their pain, occipital nerve blocks, and also there is what we do sphenopalatine ganglia block, which is very effective for also migraine headache in case of medications or Botox injections are not effective or lasting enough. One more thing, beside also epidural and facet joint injections and radiofrequency lesioning that we just mentioned, also spinal cord stimulator can be used for neck pain and radiculopathy. The same technique for the back. We do a trial for 5 to 7 days. If it's successful, a spinal cord stimulator also might be very beneficial for them.
Mm-hmm. Anything to add, Dr. Bellinger?
Not to the neck blocks really, but we are very diligent in finding the cause of the pain, and we haven't mentioned that yet, and maybe we can say that later. But I feel we do an enormous good job with contacting other physicians to work together and update primary care physicians and referring physicians about the status of patients. So there's a lot of communication going on, and that's very unique to our practice, I feel.
Right. No, you're absolutely right, Dr. Bellinger. So I don't know if some of you, the patients I know probably see that a lot of times when they go see a doctor, they're busy typing away on their laptop. And we tried to avoid that and speak directly to the patients when we see them and focus our attention on the patient. And then as Dr. Bellinger said, when our exam is over, especially on the first visit, we will either call or reach out or somehow get a hold of the treating physicians and give them just an update, a brief update on what we found, what our plans are. And then, of course, we send all the doctors a full written, appropriate consult note that's concise, accurate, and your doctor who sent you to us, or if you came to us some other way, we'll still contact your treating doctor with your agreement, of course, and just let them know exactly what's going on. And I have to tell you that physicians nowadays sometimes forget that communicating directly to another physician, either with a phone call or something such as like that, or a secure text, is something that has fallen by the wayside a little bit. We don't do that, and we feel that that's one of the many reasons why we are achieving such fantastic results as advised by the insurance companies and by our peers. So thank you for bringing that up, Dr. Bellinger. Dr. Bellinger, I was going to ask you now. We've spent time on neck pain and back pain and sciatica, and we really could spend hours and hours and actually days just on one of those topics. But moving on, there are also peripheral nerves. So we've talked about there could be problems within the actual spinal column itself, as we all discussed, problems with the disc, problems with the arthritic small joints in the back, soft tissues, nerve irritation, things of that nature. But what about the nerves once they leave the spine, when they're in the feet and they're small or the hands or other parts of the body, we can have things called neuritis or neuropathy. Can you tell us a little bit, Dr. Bellinger, about what are these neuritises? What are the neuropathies? How do you approach the diagnosis, and then we can go into some of the perhaps treatments of these neuropathies. And I guess where I'm going with this for the benefit of the patients who are listening on this webinar is that when we examine you, we're going to look at you holistically as a whole person. We're not just going to say, aha, your doctor sent us over because they think that you have a herniated disc causing your pain. Remember that 1 out of 3 patients who has a disc abnormality, that's normal. So 1 out of 3 patients normally has a disc that is pushed out but doesn't cause symptoms. So just because you have a disc pushing out on your MRI does not necessarily mean that that's where the problem or the pain generator is. We're going to also look, as I mentioned, to other structures. In this case, we're heading our direction towards peripheral nerves. And I was wondering if you could talk a little bit, Dr. Bellinger, about, as I said, the neuritis and neuropathy.
Sure. There are several reasons why the peripheral nerves that are very small can be damaged. They can be trapped in a kind of fascia or in some kind of layer of the tissue layer. So they get damaged here at that level. Then nerves can also get damaged due to some kind of systematic disease, for example, diabetes, where there are a lot of sugar fluctuations in the body that primarily damage first the nerves that are the longest in the body. So those are the nerves in the feet. Other systemic diseases can cause also problems or kind of impairment of the nerve function. For example, thyroid disease, or if patients have had chemotherapy, these tiny nerves in the periphery gets damaged first. So we have actually advanced therapy that's called Stim Wave, where there's in a peripheral neuromodulation done, so the pain perception is modulated, and that is done with a very small wire, so to say, or a lead. And that is, for example, beneficial for foot pain as well, or could be used also for any pain in the arm. And we've used that with good success, so that is another great treatment option as well.
Great. Dr. Silva, how about you? How do you approach peripheral neuropathies? And Dr. Bellinger very accurately mentioned that we can help with neuropathies in the feet. What other areas of the body, again, when you see a patient and you're working up for a possible neuropathy, what other nerves or areas of the body do you see small nerve problems?
Sure. Well, I think one of the most common is carpal tunnel syndrome. I'm sure most in our audience have heard of that. That's essentially entrapment of what's called the median nerve. And this is a nerve that controls sensation to kind of the thumb side of your hand, basically like this area. And it also controls muscle control there. And what can happen is the nerve can get basically trapped under the tissue here in the wrist, and can cause pretty significant pain, numbness, tingling, and in really advanced cases, actual muscle breakdown. You actually see nerve pain in the low back, which is pretty common actually. There's nerves that are called the superior cluneal nerves, and they run essentially over the bones of your pelvic region and the backside, and they can be a common cause of kind of low back pain that's kind of off to the side, not in the center. I think the key for any of these conditions is to, and this might sound obvious, but you first have to figure out what nerves are actually causing the pain. There's many nerves that cause pain, or excuse me, there's many nerves in the hand that provide sensation, and you need to figure out which nerve or nerves are the problem, and then you can begin the steps of trying to treat those nerves, see if you get pain relief from peripheral nerve blocks, which is essentially injecting a combination of numbing medication, steroid around the nerves, and then depending on how well those blocks work and the duration of how well they work, can guide you as to whether a patient can do well with just repeated nerve blocks, or whether devices like Dr. Bellinger was talking about, Stim Wave, which could potentially provide more long-term pain relief, might be indicated.
Mm-hmm. And you mentioned something interesting when you started. You mentioned the carpal tunnel syndrome in your wrist, and one of the things also, as we say, we treat the patient holistically. Sometimes patients will come in and say, I think I have carpal tunnel syndrome. We're gonna, as Dr. Silva said, we're gonna check that out. But also remember, if there's a pinched nerve in your neck, sometimes that causes numbness in the hand as well. And also, if someone has an arm pain, if it's their left arm, one of the things we're going to think about also is we'll ask them, have you seen your doctor? Just make sure. Sometimes a heart problem can cause left arm pain. So when you come see us, as Dr. Silva pointed out, we're gonna examine, in the example he gave, the carpal tunnel, but we're going to examine all other possibilities that might cause pain in that area. And I think that's one thing that at least doctors who send patients to us have mentioned that we do that perhaps others don't, is we're going to always dig and dig and dig and make sure that we've looked at multiple reasons for the problem to be in that particular area. Dr. Yakub, what's your approach to peripheral nerves? Do you just send all your patients to Dr. Silva and Bellinger because they really know what they're doing, or which they do? They do great. But you're an expert as well. So how do you approach it?
Well, as the doctors mentioned, we always start with the history, physical exam, because there is many things that can cause pain. Like say there is joint issues, arthritis, muscle pain. But whenever it's nerve issues, sometimes we need to do, again, I keep mentioning the EMG nerve test, which will help us actually with the diagnosis. There is different ways of treating nerve pain. Medication might help, like nerve medication, like again, gabapentin, Lyrica, Cymbalta. Sometimes muscle relaxant might help if it's there is some muscle pain also, or musculoskeletal pain. Nerve injections, specific nerve injections, certain nerve injections, as Dr. Silva mentioned, where we put small amount of steroids and some numbing medication might help. It might be repeated. Sometimes radiofrequency ablation might help with that. There is some areas like in diabetic neuropathy where we might need to do a different kind of nerve block, what we call lumbar sympathetic plexus block. In this case, the block is done in the back area. And again, it can be repeated if they feel good relief from it. Some is done in the neck area, like what we call stellate ganglia block. But small nerves, when we can do just nerve injection, and if it's successful, doesn't last enough. If even repeating the injection is not lasting enough, we can do what we call the peripheral nerve stimulation, as the doctors mentioned, where it's a simple, really simple technique, takes really less than 1 hour. It's done sometimes even without X-ray. It can be done with ultrasound technique, with just numbing the skin and putting a stimulator, small cannula next to the nerve to stimulate the nerve and block the pain. And if it's successful, again, a small implant of a small peripheral nerve implant can be done, which again take less than 1 hour sometimes, and which can help the patient with their pain. Different stimulators depending on where the pain is can be inserted at the same time.
Great. So again, just a lot of advances. It sounds like you've all brought up a lot of advances are occurring in our specialty where we can avoid sending patients to surgery. Kind of a little bit like we've probably seen in our careers where if you have a chest pain, for example, you're going to see a cardiologist before you see a cardiac surgeon. And so in a ways, that's kind of where we are now fitting in, is when someone's had any pain, and usually we say if you've had pain for at least 2 weeks. However, if it's a severe pain and you want to come in, that same day, we'll definitely make all possible efforts to get you in that day or within 24 hours. But what you're hearing from all of us say is it's exciting time for us as doctors, because we're able to help our patients with so many techniques that are now proven that the technology is just rapidly advancing, where we don't have to put them under the knife, so to speak. Dr. Belger, anything else you might want to add on any of the, the peripheral nerves, not necessarily coming from the spine, but some of the other smaller nerves? Anything else you might want to add? Or did Dr. Jacob and Silva knock it out of the park and that's it?
Yeah, I think they did. But I mean, the options are endless pretty much for peripheral nerve stimulation.
Yeah, it's so much fun to be, a physician in our specialty right now, and especially with the team we have, because right now I can say that if you come in, we can treat a pain, coming from the top of your head all the way down to your toes. And we now have techniques which we didn't have before, where we can address every little area that before we would maybe throw our hands up and say, we know what you have, we just don't have the mechanism yet to treat it. And I'm sure with time that's even going to get better. I'm going to go back a little bit, and one of the questions we had from the audience is kind of a basic question on there's different types of steroids. There's bodybuilding steroids. There's steroids that make you win the Tour de France. But how do epidural steroids work? What's that mechanism? I don't know, Dr. Silva, maybe you want to address how do they actually work? What does the epidural cortisone actually do? And I know we're using very tiny doses, but how does that work?
Sure. Well, the basic premise of steroid in general is that it's what we call an anti-inflammatory medication. So it essentially reduces the body's inflammation response to any sort of injury. Inflammation can be caused by infection, it can be caused by trauma, it can be caused by stress. In the case of an epidural, usually what happens, let's take sciatica, for instance. That's kind of the quintessential pain that people think of shooting down their leg. What's often actually occurring is that you have a disc that people think of called a slip disc. And what's happening is essentially the disc is bulging out and potentially irritating one or more nerve roots. And it's not often the disc itself that causes the problem. It's the fact that the bulging of the discs causes an inflammatory reaction in that area. And that inflammation can irritate the nerves, kind of the same way that if you cut yourself, that area that's healing, it gets red, it gets swollen, it gets irritated, it's painful. So it's the same idea. And what the steroid is doing is the steroid is calming down the inflammation in that area, calming down the swelling, calming down those chemicals that are causing the irritation. And oftentimes that can be sufficient to stop the patient's pain. That's why you'll see an MRI of a patient who has no pain, but they have bulging discs. And the reason they don't have pain is because the discs are not causing inflammation. Certainly, as Dr. Prunskis alluded to earlier, if the disc is bulging so severely that it really compresses the nerve and you actually have motor weakness, then that is when you'd need to get a surgeon involved, because now you're no longer just concerned about inflammation. You're concerned about a real structural, permanent structural damage to the nerve. But the epidural essentially works to reduce inflammation. And the reason it can sometimes take a couple series of epidurals is because I tell this to patients all the time, if you get sick and you need an antibiotic, you can't pop all the pills at once, or you can't take one pill, you might need to take 7 days worth of pill. It's the same idea. The body naturally removes any medications that it sees. So the steroid is not going to sit in the epidural space forever. It's going to do what it can before the body removes it. So it can occasionally take a couple rounds of inflammation reduction to start to see really substantial results.
Very good. Got it. Now, are these steroids, are they going to make my muscles big? Is that the kind of steroids these are? Or are they different type of steroids? Will I be looking like a bodybuilder, or do I have to hit the gym? So that's of course. So of course, these are very specific anti-inflammatory cortisones. They have a very specific role to, as Dr. Silva properly pointed out, shrink down the tissues, and we use very tiny quantities, much lower than if you took oral steroids. When you take oral steroids, remember, it goes to your stomach, it goes to your liver, it goes to your whole body, and the actual amount that gets to the problem area is very small. So with our precision techniques, we're able to deliver a small amount of medication right where the problem is. And so we don't minimize any potential side effects. Maybe Dr. Jakob, you could talk a little bit about what does it mean we say we use image guidance? I mean, how do we know that where we're putting these various medications, where we're putting these various devices we're talking about? How are we sure? What do we, people say, what's a fluoroscope? What's ultrasound? Maybe you could touch on how we're sure that we're precisely putting the medication where it needs to go.
Sure. It depends on the procedures or surgery we're performing. Epidural injections, let's say, or facet joint injections are done with the fluoroscopic guidance, which means we're using X-ray, somehow similar to the one they use to do chest X-rays or any other X-ray, abdominal X-rays. This way it's safer, it's easier, and more precise, and we know where to put the medication exactly. Sometimes most of the time we use also contrast, as long as there is no allergy to contrast, which show us some areas where we cannot see them also with the X-ray. Some areas you cannot see them, like the bone, you can see the bone with the X-ray. Some soft tissues like the muscle, you might not be able to see them. So injecting some contrast will show you the muscle, or will show you the nerve. It goes around the nerve and it will show you the structure that we're injecting. Ultrasound can also be used for nerve blocks, for also trigger points injections or muscle injections to put the medication exactly in the right spot. So fluoroscopy or X-ray can be used for different techniques like facet injections, sacroiliac joint injections, epidural injections, and also for muscle injections like piriformis injection, for example.
And you mentioned fluoroscopy, and one thing is that fluoroscopy is an extremely low dose radiation, so it's much lower than conventional X-ray. As a matter of fact, when you go up in an airplane, you get more radiation than you do from the fluoroscope. So it's a very limited exposure, but it helps us, as Dr. Jakob pointed out, get precisely into the area. So as we're wrapping up, first of all, thanks to our expert physician panelists, and thank you to those who have tuned in. And this actual webinar is going to be posted permanently. So if you have any friends who you think you might want them to see what we talked about, they'll be able to tune in and listen to this program at their own time. And as I'm going to ask the panelists for final thoughts and on the topics we covered, Dr. Bellinger, what final thoughts, if any, might you have that maybe come to your mind now that you want to make sure that the people who are listening take home with them?
Well, we surely, I think, make a great effort of finding really where the pain is coming from and do our best to treat it. That's that's what I'm passionate about.
Okay.
And I think the whole team is, so.
Yep, passion. That's a great word. Passion and compassion, compassionate. We know that when you're coming in, the first day we meet you, we know that you're at your worst, and we recognize that. You might, so we understand that. Dr. Silva, anything that you might want to add or wrap up?
I would just say that, most of the patients we see, have had pain for a while. And I try to help them understand that, can be a chronic condition, and that sometimes it's better to look at it, the way you might look at diabetes or high blood pressure. But there are a lot of options out there. Some of them are actually curative. Some of them are more management based, the way a patient might take insulin for diabetes or blood pressure medication for high blood pressure. But there is a lot out there. And even if something can't be absolutely cured, or a patient doesn't want to undergo surgery to try to cure it, that doesn't mean that they have to live in pain with what they have, that there are many options out there to if not completely eliminate the pain, certainly, improve quality of life substantially.
Absolutely. Yeah, great. Dr. Jakob, any final thoughts?
Well, they need to know there is different conditions that can cause pain. Sometimes it goes away on its own, or using maybe simple over-the-counter medications might help. But we're here for them whenever this is not working, or whenever, let's say, they feel there is something weird, like numbness in their hands or legs, which was not there, or some weakness. They need to seek medical attention in that case. And there is different things we can do, different kind of treatment.
Great. And my wrap up, I'd kind of just want to review how we started. And, again, just reminding people that at the Illinois Pain Institute, we are not treating any COVID patients in any of our facilities. We are actively screening those patients away that might have symptoms so that they can get the care they need, trying to ensure the safety of our staff, ensure the safety of our other patients. And also, we are not in a hospital. So many patients are fearful, and there's reason to be, because the sickest patients are right now in hospitals. And when you see us, we are outside of a hospital system with our accredited surgical center and our freestanding sites that are in 4 counties: Lake County, McHenry County, Kane, and DuPage counties. And as the doctors here mentioned, one of the things that we strive to do is the relentless pursuit to do the best we can at finding the source of your pain. And then when you have questions, please ask your doctor, go over the risks, the benefits of any procedures, potential complications, and just so you have the peace of mind that the options have been explained to you. You know that if you need a procedure, you have the ability to have it with sedation, so it's comfortable, and that the majority of patients that come see us don't need surgery, will not have to have surgery, and are usually able to have a substantial improvement in their pain compared to the day that we met them. So on behalf of the doctors here, Dr. Silva, Dr. Jakob, myself, Dr. Bellinger, Dr. Terry Dallas-Prunskis is not part of our panelist, and Steve Perry, who is our physician assistant, is not part of tonight's panel. However, they will be on future panels. We thank you for your time, and if you have any questions, please don't hesitate to contact us. Thank you, and have a good day.
Thank you.
That was really excellent, you guys. Good job.
Thanks.
Okay, well, very good. Thank you. I turned my camera off. I saw, thank you again for putting this together. You just make it so easy.
Well, you guys did a great job. It flowed beautifully, I thought, and we'll have the recording all ready for you guys. You had a really, really strong attendance too, so we'll definitely have it available for you. But you guys, you did great. You really, all of you sounded amazing.